Bismillahirrahmanirrahim. Assalamualaikum and very good morning to everyone. And thank you for Dr. Azrin for being here. Before we start, a little bit of an introduction about our topic today, first thing in the morning. Dr. Azrin binti Abdullah, Assistant Professor from Kuliah of Medicine IIUM, will be having a lecture on cardiovascular physiology this morning. She attended her basic medical bachelor degree from the University of Adelaide and Doctor of Philosophy in Physiology from IIUM. Without further ado, I welcome Dr. Azrin for the lecture.
Okay, thank you very much for the introduction, kind introduction. Alhamdulillah, the second time and seeing you this week. Yeah, again, I would like to highlight, it's very cool of the organizer to cutting short my 7 sessions, or it's actually 8 sessions of lecture into one. So, jangan report pula, keluar in a very friendly way, okay? So I purposely highlight that so that you're aware that it's impossible to do the revision within 1 hour, but I would like to just extract the topics or the aspect of cardiovascular physiology that will somehow help you to revise as much as possible. Okay, so it's a modified version, my modified version of revision for the postgraduate clinical postgraduate. Now, let me just start sharing. Can you see the slides at the moment? It should be. Can you see the slide now?
Yes.
Yes. Boleh ya? All right. Okay. Okay. Suddenly baru bangun pagi, suddenly tak menghadap lecture lagi. You know why is it taking so long? Okay, now. Right. Just move my name away. Picture. Now let's move on. Alamak, saya lupa lah sekejap lah. sorry, I forgot to show you. Yeah, alright dah. Sharing again. Bear with me. Now, mana saya punya? Okay. Now, I would like you to read quickly 2 scenarios. Kata orang soalan essay lah, asked before, and this is one of the questions that I asked by lah. Okay? I'm happy to share because I don't think this year I'll be called because of the pandemic. But it was intensely discussed at that time with also one of the professors. It's quite interesting actually because it combines your knowledge of autonomic nervous system. Okay, so this is one scenario. Just have a read, and at the end of the lecture, if you have time, you will revisit. And I do have some answer scheme for you, inshallah. So this is one. A healthy athlete, purposely put there healthy to give you a hint. Yeah, it's about to perform a 100-meter run, and then just random who checks, like maybe in a research setting, a random check of his blood pressure shows his systolic blood pressure of 139 and his diastolic pressure of 85. In other words, high normal. Yeah? So usually athletes will expect it is lower Okay, so we are supposed to discuss the mechanism that cause the blood pressure reading. Of course, in Viva or in essay, the question is quite straightforward, but in postgraduate, you expect to explain the factors, the determinants, then you start talking about the regulatory mechanism. Okay, this is another scenario. Another healthy male presents to the emergency department with profuse bleeding, and it's due to several stab wounds. And then on examinations, his extremities are cold and clammy, and his pulse rate is 120 beats per minute. His mean arterial pressure is 45 millimeter mercury. Those are the questions that I actually ask the students, like in Viva, in a very friendly way, of the subheading, or sometimes I just start with the first question and then the student lead me to the rest of the question. Like I said, remember the first lecture, you lead the lecture examiner. Yeah, don't let us stop. Okay, now, so basically, why I say it's so mean to make me talk in 1 hour, because it's usually covered more, at least 7 series of lectures. We've got hemodynamics, cardiac output, cardiac cycle, electrical activity of the heart, ECG lah. Kan? Itu ECG pun ada 2 actually, 2 hours. And then we have the regulatory mechanism of the heart. Mana pergi blood flow tu? Sorry about that, chopped off somewhere. And then we talk about the regulatory mechanism, in particular the blood pressure, and then followed by the regional blood flow. Because there's some exception. Remember the autonomic nervous system, with the cardiovascular system, also there's some exceptions. Okay, so with the regional blood flow, we explain what are the mechanisms applied locally, okay, for survival of its region lah, right? And then we also have another lecture. I forgot to put it there. In other words, applied cardiovascular physiology, like exercise physiology. So hari ni everything in 1 hour. So ada exercise physiology semua ada. But inshallah it helps. So hopefully by end of this session, you'll be able to describe arterial pressure in the systemic circulation confidently. Yep, in particular about the systolic diastolic pressure, the pulse pressure, and the mean arterial pressure lah. Boleh regurgitate. So like in Viva, we'll start with, tell me about the blood pressure. What do you know about the blood pressure? Mula define, that's it, and stop. No, keep talking. What are the formula? How do you measure? The definition, to just stop. That one alone is probably about 3 minutes. Habis dah, maybe siap. And then talk about the relationship between the arterial pressure and cardiac output and heart rate. In other words, the determinants. What are the factors that affect blood pressure? And then what are their relationship? Inverse ke, proportionate ke, kan? And then compare. When we have determinants, when we have factors, how do we control them? So it's called the controlling mechanism or the regulatory mechanism. So when we have blood pressure, how do we regulate them? The short term and long term. We need, at your level, definitely you need to compare the short and the long term. Tak boleh just cerita je, you must point out specifically. Some of you have already given this lecture, right? And then you need to know the examples, the major examples of each short-term and long-term blood pressure regulatory mechanism. No one example. Usually favorite vasoreceptor reflex lah for the short-term. And the long-term is the RAS, renin angiotensin aldosterone mechanism. Confidently talk about it. It's like rugi lah kalau lecture tanya, you tak boleh jawab. So anyway, if you know all this, insyaAllah lulus. At least lulus lah kan. Bukan nak suruh you dapat distinction kan? InsyaAllah. Aim high, at least saya jatuh pun to the second floor, not to the ground. Now, so let's go to the first learning outcome, which is to describe the parameters involved ataupun the hemodynamics of a cardiovascular system. You all dah bangun dah ni? Dah minum kopi dah? So let's start. So first kali, so like I said lah, this is a revision, this is not a lecture or year 1 lecture. So I will start like in Viva. So tell me about the arterial pressure. Okay, so you talk about the blood pressure is the pressure exerted to the wall of the blood vessels. It can be measured by the sphygmomanometer, and then it is in the blood vessels. What's measured? The effective pressure that is imported in the systemic circulation is the mean arterial pressure. In other words, the average pressure that's exerted into the cardiovascular system with each cardiac cycle. Okay? And then it can be calculated using this formula. Okay, so kena hafal ya, unfortunately kena hafal. Because why? This formula explains to you that diastolic pressure is more important than systolic pressure. Kadang-kadang adalah soalan distinction. Nak tanya, so which way of diastolic and systolic pressure, which one is more important? The diastolic pressure, because just by looking at this equation, the mean arterial pressure, the calculation involves the diastolic pressure and the pressure difference between systolic and diastolic. All right, so in other words, calculation the parameters of the diastolic pressure is taken into consideration twice. So this formula stresses the importance of the diastolic pressure as the more important factor in determining the function of the cardiovascular system, in particular in supplying nutrients, in conveying nutrients to the tissues, okay, by having an optimum blood pressure. So, ni jangan salah sebut MAP, millimeter of mercury. Tadi sebut millimeter mercury. Okay, kalau dengar tu indicator, so it's not correct as well. Not 100% correct lah millimeters of mercury. Dapat yang very particular examiner macam saya kan, tak nak beri sensation lah, tak boleh, tu aja. And the kindest of all. Right, no. Now, so please, and when you talk about the mean arterial pressure, it can be measured by this formula. Usually we give you a piece of paper in front of you, and then you start scribbling. And then what is the definition of systolic blood pressure? What is the definition of the diastolic blood pressure? So the definition has no lah kan. Of course, systolic blood pressure is the maximum pressure that you can measure, and it's during the ventricular ejection of ventricular systole. And then contradictory to the diastolic blood pressure is the minimum pressure in the ventricle during relaxation or during diastole. So in another definition for systolic blood pressure is the force at which heart pumps blood around the body. Okay, so what amount of force are required for the heart to exert in order to be able to supply the content of blood to the rest of the tissue. And the resistance to this flow within the blood vessels is considered as the diastolic blood pressure. Okay, so if you have very strong heart, if you increase the sympathetic, for instance, you increase the sympathetic activation, and there's increase in cardiac contractility. But if the resistance in the blood vessel is very high, very strong, resistance is very high, that's the appropriate way of saying it, then it's difficult to achieve optimum it's difficult to achieve the optimum function of the cardiovascular system. And so how can resistance be very high in this instance? In elderly lah, okay, because the vessel becomes very hard and stiff, less compliant, so the resistance is very high, even though the hearts keep pumping harder and harder. Right, so that's the difference. Definition of this, forgot to put satu lagi definition. So you need to mention about the pulse pressure, because pulse pressure, as you know, can indicate certain pathology, especially when it comes to valvular dysfunction. Okay, so it's the pulse pressure is the difference between the systolic and diastolic lah, the maximum and the minimum. Okay, right. Okay, right. Now, semua definition satu, so dah dapat dah at least 5 markah. Okay. So now, what are the relationships? All this definition and all this definitions. When you want to talk about the relationship, you need to mention the factors, the determinants that affect these parameters mentioned. Okay, so the mean arterial pressure is determined by these two parameters, cardiac output and the total peripheral resistance. Alah, lupa lah nak pasang. Okay. Right. So this the two determinants. Now the relationship is simplified in this equation. MAP, mean arterial pressure, equals to cardiac output and total peripheral resistance. In other words, it's proportionate lah. So higher if the cardiac output is high, and mean arterial pressure is high. Same, total peripheral resistance is high, then the blood pressure is also high. Okay, now, so remember this equation. Now, usually in Viva, we love to ask you, okay, since you mentioned already cardiac output and total peripheral resistance, just keep talking. What is cardiac output? So what are the determinants of cardiac output? The determinants of cardiac output is stroke volume and heart rate. And then we start asking, what is the determinant of stroke volume? Okay, cakaplah determinant of stroke volume is ada 3. Right, so before that, be clear about the difference between cardiac output and stroke volume. Cardiac output ni is about flow. Stroke volume is about volume lah. Okay, so cardiac output is derived from the flow equation. Tu kena buka balik hemodynamic lecture, tak habis dah nak cakap within 1 hour. So the volume of blood that is actually pumped out of the heart in 1 minute is actually the cardiac output. Okay, right. So it will be very efficient if you can pump, very sufficient. That's why sometimes if the cardiac output is insufficient, even though you have increased heart rate, so you cannot achieve the function of the cardiovascular system in conveying nutrients of oxygen to the respective tissues. Now, and then stroke volume is, of course, talk about volume with each contraction. So cardiac output is about flow, how much of blood is being pumped in a minute. Stroke volume is about the volume each contraction. Right. So mean arterial pressure determines cardiac output and total peripheral resistance, and cardiac output determinants are the stroke volume and the heart rate. Now, stroke volume. So called stroke volume. What is stroke volume? So stroke volume is represented by this equation. So stroke volume is N diastolic volume minus N systolic volume. So N diastolic volume, kena buka balik, but just quickly, is actually the amount of blood at the end of diastolic during relaxation of the ventricle. So berapa left? Okay, and then, okay, all right. So and then N systolic volume is the amount of blood at the end of systolic. Ada remnants tak? Okay. So from this equation you tahu dah, if at the end of each contraction, ventricular contraction, kalau ada banyak baki, ada banyak residue of blood, amount of blood, stroke volume will be less. Okay, all right. And then if there's more blood during end diastolic volume, at the end of the diastolic, the stroke volume will increase. Okay, so because of this equation, because of this equation, therefore, the factors that affect stroke volume are these 3: the preload, the heart contractility, and the afterload. Okay, hafal So what is preload? The pressure, the filling pressure of the heart at the end of diastole. So preload, because whenever blood return to the heart, venous return to the heart, to the atrium, and then to the ventricles, that is filling pressure. So at the end, the preload will determine how much contraction the heart, the myocytes, the cardiomyocytes will exert. Okay, so this is based on the Frank-Starling law. So contractility here, when we talk about contractility, there are 2 determinants, of mechanisms. The 2 mechanisms that can affect heart contractility: Frank-Starling law. When we talk about the preload, we talk about Frank-Starling law. But when we talk about the autonomic nervous system, it can also be increased. The heart contractility can also be increased by the sympathetic activation. Now, so just now we know stroke volume, the determinants have 3 components. The preload, so preload is the pressure that will determine the stretching of the cardiomyocytes and determine the contraction. So the more it's stretched, the harder the contraction, the harder the contractility is. And of course, it will increase the stroke volume. So that I've mentioned, when there's a sympathetic activation, it will also cause increase in contraction, right? The strength of contraction. But when you want to relate with preload, when you want to relate sympathetic activation with preload, you can also relate to the venous constriction, the constriction of the veins. Because when the veins constrict, the venous return will increase. When venous return increase, the preload increase. And as we already know, when preloads increase, stroke volume also increase. So when stroke volume increase, cardiac output increase, arterial pressure also increase. So see the relationship, So Continue talking. Just now about preload, now talk about, so in conclusion, yang kat bawah ni saja, the rest is the same. So stroke volume, represented by the equation just now, ADV minus ESV. So the determinants are these three factors. So increased preload will cause increased heart contractility, and in relation to preload, it's due to two things. In relation to preload, is due to Frank-Starling law, and then also the venoconstriction, and then at the end of it, the increased preload, the increased stroke volume first increase the mean arterial pressure. To summary. Now, let's go back to this equation again. Okay. Lagi nak cakap tu ya. So tadi the mean arterial pressure, kalau that's why sometimes when we a bit cheeky, when we ask them how many factors affect mean arterial pressure, the students say 2, cardiac output and TPR. And I say no, it's not 2. There's more. Actually, saya break up. You just break down the cardiac output punya determinants lah, kan, which includes the determinants of the stroke volume, which is the preload, heart contractility, and afterload, and of course TPR. So, kenapa saya letak TPR, the heart rate kat sini lah, heart rate. So actually there's 1, 2, 3, 4. Because why? Afterload is actually amount the pressure that the heart has to overcome. The pressure is where? Afterload is the pressure at the blood vessels, at the peripheries, that the heart needs to overcome in order to perform, in order to expel blood from the heart to the blood vessels. So that's afterload. Okay, so it's actually about resistance as well. So that's why I just put them together. So the determinants of blood pressure, it's not just 2, there's actually 4. Okay, see how summarize. So macam tu saja, habis dah saya punya time. Lepas tu next lecture pula cakap, next examiner pula tanya soalan. Habis dah. Okay, now so this is in general, when we have factors, we need to know the regulatory mechanism as well, right? So for the heart rate just now, tadi dah saya sebut dah, the stroke volume, the heart rate, of course, like what we've learned, there's autonomic nervous systems can affect the heart rate, and don't forget the hormones. When we talk about hormones, remember the adrenal medulla, they will excrete the catecholamines that has predominantly adrenaline and noradrenaline that can cause increase in heart rate as well. Okay, now this one all dah tahu dah. So this is how it's recorded, because some of it is adapted from the first year, guys. So then put that on macam mana. Alright, so remember what is normal. Right? Remember our the athlete just now. So the new, of course, now there's classification, the new classification, but still will take 140/90, right? Okay, but of course, if you want to start, we want to consider risk factors. We have now classified blood pressure into high, normal, or optimum normal. Okay, so the mean arterial, the normal pulse pressure is about 30 to 40, and then the mean arterial pressure is about 90. It's considered normal. Now, coming to the third point of the third learning outcome for this revision session. And now that you know the parameters, now that you already know the factors that affect the hemodynamics and the factors that affect the blood pressure, you need to know ways of controlling it. And how to control it, we can have a quick one or the long-term one. Quick one is the short-term lah. Okay, so when we talk about short-term, and long-term blood pressure regulatory mechanism, you must be able to appreciate 3 main factors that differentiate these 2 categories. All right. In terms of the response, it produces the blood pressure changes, whether it's quick or a bit delayed. Yeah, it's still efficient, but not as quick as the short term. The long-term blood pressure mechanism is still efficient, but it's not as quick the response as the short-term blood pressure mechanism. So, first characteristic, you need to differentiate the 2 in terms of its response. In producing change, blood pressure change, and secondly, how is the change? How is the change being mediated? What is actually change? Is it the blood vessels diameter, or the heart rate, or the contractility? So those that I mentioned is specifically for the short term, and then for the long term, basically it manipulates, it changes the blood volume. Okay, so we know these components, these parameters are regulated, through the different regulatory mechanism. So the short term, the regulatory mechanism is through the nerves, the manipulation of the nervous system. Okay, and whilst the long-term blood pressure regulatory mechanisms, the hormones, the endocrine system mediate the changes of the blood volume. See, so that's the difference. Okay, so appreciate these differences between those two categories of blood pressure regulatory mechanism. So what the short term produce very rapid, meaning seconds to second change. If you want to talk about acute change, second to second, then the blood pressure regulatory mechanisms involved is the short term. Jangan bagi example yang salah. Right, and then the long term, it takes about a few minutes to several days before it can produce optimal blood pressure change. Okay, and as mentioned, the long-term blood pressure regulatory mechanism involves the mediation of hormones, the endocrine system, in particular the RAS. Ada few like the peptides, but it's not as vital. Okay? More studies being done lah right now. So dah boleh appreciate the differences. Now you need to start talking about the examples of each. So memang favorite is the baroreceptor reflex for the short-term blood pressure regulatory mechanism. Okay, but don't forget there's also chemoreceptor reflex, and there's also CNS or central nervous system ischemic response. So these three you still need to know and differentiate. Which one is being triggered at what level of mean arterial pressure. Just if you can compare that, that's good enough. Okay, tak payah stress. Remember kita nak pass kan? That stress will cause you to forget. Now, so this is what I meant. When you want to compare the short-term blood pressure regulatory mechanism, you compare in terms of the blood pressure that will activate this, either of them. Okay, either three. These are the three main, the most common. Of course, you can do some other, but three main ones. If you can just happily compare, we'll be quite happy to give you distinction. Now, so baroreceptor reflex, as you already know, is a negative feedback mechanism, and it starts to be activated at mean arterial pressure 60 millimeter mercury. Okay, however, it is, as mentioned, it is an efficient system that is to reduce blood pressure, negative feedback mechanism. The activation is the stimulus is quite high blood pressure and cause reduction, but it can still detect changes. It can still convey messages to the integrating center, okay, and then exert appropriate change to the circulatory system or to the heart, and then aim to maintain the optimum blood pressure. And it's more efficient in maintaining narrow range of blood pressure, like about 85 to 100 millimeter mercury. Okay, right? Sebab kalau otherwise, maknanya, it explains why it's the most important short-term blood pressure regulatory mechanism lah. It's very vital when we want to, it decides whether or not its patient is stable or in critical condition and require extra hemodynamic support. Okay, so secondly, kalau chemoreceptor reflex pula, this mechanism will be stimulated when the mean arterial pressure is 80 millimeter mercury or lower. Wait lah until it reaches 60, then this one starts to take over. So the chemoreceptor reflex, its main function is for the respiratory system, but it does have some cardiovascular function. So the cardiovascular function, even though it's minor, but it can cause blood pressure change, especially when the mean arterial is reaching 80. Remember tadi sebut the normal MEP is 90, right? So when it reaches 80, usually the chemoreceptor reflex will be activated. Another example of short-term blood pressure regulatory mechanism is the CNS, central nervous system ischemic response. The name tells you It's the final backup system, yep, to maintain the most important organ, which is your brain, okay, to prevent ischemia. So when the blood pressure is really, really low, MAP is 60 millimeter mercury. So this is the short-term quick response that will regulate the blood pressure and exert quick outcome. Yeah, all right, in order to maintain survival of the brain tissues. Right. So this is the pathway. Remember the pathway of the because it involves autonomic nervous system, the baroreceptor. So the pathway that when you talk about the baroreceptors pathway or its activation, talk about the apa nama? Reflex. Yeah, it talks about the components of the reflex arc. Meaning you need to talk about the stimulus, you need to talk about the receptors, you need to talk about the afferent nerves, and you need to talk about the integrating center, okay, and you need to talk about the efferent nerve. All right, so this is the most important part. Yeah, kecil-kecil ones, if you don't remember, still forgiven. All right, now, so the pathway, the baroreceptor pathways, you need to appreciate between the two, you need to differentiate the pathways of baroreceptor reflex and chemoreceptor reflex sebab dia dekat sebelah. Sebab baroreceptor reflex receptor, the baroreceptors is at the carotid sinus. Kalau yang tu dekat mana? Body. Kalau chemoreceptors, dia dekat carotid body. So it's a bit confusing, ya. And then kalau dekat aortic, dekat aorta for the baroreceptors, they are placed they can be found at the aortic arch. Okay, so remember it's a mechanoreceptors, so it is stimulated by stretch. So this is my summary. What happened when the blood pressure is increased and when the blood pressure drops in the baroreceptor reflex. Remember, being a negative feedback controlling mechanism, the way you explain to shows whether or not you hafal ataupun you understand. All right, because blood, remember, it is activated, yeah, when the blood pressure is high. Yeah, the stimulus is high in blood pressure, the baroreceptors will be stretched. Okay, so activation occurs when the blood pressure increases because it stretches the baroreceptor. Okay, so this stimulus will cause activation of the CIC, cardioinhibitory center, that triggers the activation of the parasympathetic activity. And then this as for the CAC, cardio acceleratory center, it will reduces the sympathetic activation. Yeah, okay, right, because the stimulus is high, increase in blood pressure, the negative feedback mechanism of the baroreceptor will cause a decrease in sympathetic activation, like increase in parasympathetic activity. So contradictory, yeah, remember, use the right word. Okay, so when the blood pressure drops, baroreflex activation decreases. Tak boleh kata dia stimulate, kan? No, because that means the actual potential, because there's less stretching of the mechanoreceptors, so it will cause a reduction in actual potential propagation from the baroreceptors, and then the integrating center receive this detects this reduction in actual potential propagation, and then attribute this and then will translate this information by choosing to activate the CAC of the vasomotor center, which is a center for the sympathetic activity, and causes sympathetic activation and contradictory cause the reduce in parasympathetic reduction. So the difference is it reduces when the blood pressure drops, baroreceptor reflex receive activation is decreased, thus activates sympathetic activity. Alright, so cara cerita tu sebenarnya sama je lah outcome tu, yes, tapi cara cerita tu nampak saya hafal. So of course at the end we aim to restore the blood pressure. Now, so this is the detail of what happened lah. If let's say, sometimes I just want to stop at baroreceptors, although I expect to explain further what happened actually. So this one distinction we can mention about the sodium influx, and then that triggers the actual potential. And of course, you we mentioned this is for distinction. Tadi saya cerita tu untuk pass. We nak distinction, we mention lah from the carotid sinus, white nerve, that's glossopharyngeal nerves, and from the aortic arch, and the afferent nerve is the biggest nerve, and then you bring this information, the propagation of action potential will be detected by the integrating center. So integrating center tu kena sebut lah apa dia. Ni lah distinction. Nucleus tractus solitary that integrates the all sort of input and then decides on what sort of output ataupun how to respond to the stimulus. Okay, so ini semua just basically apa yang saya cakap tadi. So the notes nanti you can refer. So just I want to point out here, just now as for in general, when you have to relate at the effector organ. Remember part of the autonomic nervous system, we talk about the effector organ. So when you want to talk about blood pressure, remember this equation. So you have to discuss in terms of the heart and the blood vessels as well. So sometimes they don't nervous, but the heart the blood vessels. So when the blood pressure rises, the CIC will be activated. In NTS, the integrating center for the cardiovascular system is nucleus tractus solitary, will cause the CIC to be activated. And CIC, cardio inhibitory center, will increase the parasympathetic activity, and this parasympathetic activity, the parasympathetic nerves that synapse to the heart will cause release of acetylcholine. Kena sebut lah, acetylcholine that binds to the cardiomyocytes membrane, which has muscarinic receptors. Okay, so in the heart, if it's the pacemaker cells, it causes reduction of the heart rate and reduce the conduction of the impulse, the electrical activity, right? And then if it's the cardiomyocyte contractile cells, it reduces contraction. Okay, and the net effect of this will reduce the cardiac output plus reduce the blood pressure. Tapi remember, when you talk about blood pressure rise, even though the CIC is being activated, what happened to the CIC? CIC detects, the NTS detects, and then tell the CIC no need to exert any influence. Okay, so reduce your activity. So this reduction in activity or sympathetic activation cause less vasodilation in the blood vessels because the vessel constriction is less, and then cause reduction of the heart rate and cardiac activity as well in the heart because of the reduced sympathetic activity. Okay, so of course, it also complements the effect of the parasympathetic activation, in other words, reduction of cardiac output and reduction of the blood pressure. Okay, so when you talk about blood pressure rise, remember that I said a few days ago, the parasympathetic system has little or no effect on resistance vessels, on the arterioles, and so therefore it doesn't really affect much of the total peripheral resistance, okay, because it has very limited innervation on blood vessels. Okay, so except for those two organs lah, penis and the clitoris. So when you want to talk about reduction, parasympathetic activation, focus on the effect on the heart, not the blood vessels. Betul-betul faham lah saya lecture. Kalau saya dapat, saya happy. Oh, faham. Definitely saya dapat lah distinction. Now, right? So now, tadi, ni terdouble pula, sorry. Okay, now let's talk about the drop in blood pressure. So when there's the drop in blood pressure, tadi dah sebut, dah katakan in summary what happened. So there's a decrease, the baroreceptor noted reduction in blood pressure, and then there's reduction in action potential conveyed or propagated through the afferent nerves. Okay, so what happened? The NTS will stimulate the CAC, the vasomotor center or cardio acceleratory center, and cause sympathetic activation. So when you talk about sympathetic activation, you talk about increase in the heart and the blood vessels parameters or hemodynamics. Okay, so how this is being exerted through the, remember, neurotransmitter, adrenaline in particular, because we want to talk about increase in TPR, and no adrenaline, but adrenaline causes vasodilation. So So release of noradrenaline by the sympathetic nerves will lead to the appropriate response required to increase the blood pressure. And at the same time, talk about the CIC, it receives less stimulus from the NTS or integrating center and cause a decrease. So there's a decreased effect on the parasympathetic in the heart. Bisa tak sebut pun blood vessel, because remember parasympathetic later on no effect to the blood vessels. Now, so what happened in the heart? When the blood pressure drops in the heart, remember tadi saya sebut, kena sebut, dia tadi sebut noradrenaline kan? So noradrenaline binds in the heart, it will bind to the pacemaker cells and cardiomyocyte cells, the contractile cells. Okay, so the receptors responsible is the beta-1 adenoreceptors. Jangan sebut yang beta-2 because beta-2 only in the blood vessels or the coronary circulation. Okay, for local blood flow, if you choose to maintain local blood flow in the heart. Okay, so this, the blood pressure drops will also cause in the end, the end product, because of the increase in heart rate, increase in chronotropic, the positive chronotropic, the positive chronotropic and positive inotropic will cause increase in the stroke volume and then increase in cardiac output. Okay, right. So that's now is the heart. Now the blood vessels, the alpha-1 adrenoreceptors will, when the noradrenaline binds to it, it will cause vasoconstriction and then increase the TPR. The veins, remember the veins, venous constriction cause increase in venous return, increase preload that will increase stroke volume. Yang ni tadi increase TPR. So the net effect is increase cardiac output and then increase mean arterial pressure. Nampak ya? So how they are related? So you cannot stop at the regulatory mechanism. Sorry ya. Okay. Ada interference. Now, nak habis dah? Tadi dah short term blood pressure regulatory mechanism. Compare the short term and long term. Compare the short term, the three different important short term regulatory mechanism, and then explain the baroreceptors. Now let's talk about the long term blood pressure regulatory mechanism, and then I'll focus on the RAS. Okay. Now, as you know, long term, ambil masa the endocrine system because the hormones released in one organ and the effect is seen in a distant organ. Yeah? That's an endocrine system of the hormones. So it, of course, it will take a longer time, minutes to days, to maintain appropriate response. So it involves the manipulation of blood volume, okay, and then blood volume, as we know, the determinants of blood volume in arterial blood pressure, long-term regulatory mechanism is the effect of the venous return and the end-diastolic volume, and we know end-diastolic volume is actually preload and also the heart contractility that affects stroke volume then cardiac output and the mean arterial pressure. Okay, senang kan? Nampak macam tu. Now, when you talk about the long-term blood pressure regulatory mechanism, okay, the volume can be increased. The blood volume or the sodium can be increased by the two systems here, RAS and also the antidiuretic hormones, not just the manipulation of water, but sodium mainly is the manipulation or the effect of RAS, and the antidiuretic hormone or the vasopressins affect the water retention. So when that's when there's increase in that's to increase ECF lah. Okay, in order to decrease the volume, blood volume, the hormones involved is this one I give example of atrial natriuretic peptide. There's also brain natriuretic peptide. So because it's found in the brain, right? So this one is found in the atrium. Okay, so this one will be released. This hormone will be released when there's increase in volume. Okay, so of course the effect will be reduction in volume. Okay, so these are the two main examples. Tadi dah sebut dah short term apa examples here. This is the examples of the hormones involved in manipulating the blood volume and then changes the blood pressure. Okay, so now let's look at the RAS. Now RAS, Please appreciate that RAS is affected by the change in renal blood flow, or in other words, the mean arterial pressure is reduced. Okay, so what happened? So when there's a reduced in renal blood flow, the granule cells of the juxtaglomerular apparatus. Saya suka tanya ni, kat mana? Cerita kat mana? Apa suka tak tahu. Jangan tunjuk kidney pun tak apa dah. Right, so this will be detected when the renal blood flow is reduced. Okay, the JGA will then secrete renin into the blood vessels. Okay, so renin will act as enzyme. Even though it's a hormone, because it will be excreted and then cause effect elsewhere. That is a hormone. But in terms of what it actually does, it acts as an enzyme. Sebab tu jangan confuse. Sometimes you think MCQ, apa ni jawapan the enzyme? Because what it does to angiotensinogen, okay? Because what it does, it slices so that it becomes angiotensin 1. Okay, so renin is found, it's released, okay, tapi it's released to act on angiotensinogen that is synthesized by the liver. Semua tak ada sebuah berlaku dekat sini. Okay, so this angiotensinogen is that's found in the plasma, then will then converted when it's sliced by the renin, converted to angiotensin 1. So angiotensin 1, once it passes in the circulation, once it passes the pulmonary capillaries, the circulation in the pulmonary, the lung circulation, okay, it will then be converted to angiotensin 2. This is the act of the angiotensin converting enzyme, the ACE. So this enzyme is found in the lung. Okay, so that means angiotensin 1 will be taken to the pulmonary capillaries and then transform angiotensin 1 to angiotensin 2. Okay, that pulmonary circulation. Right? So then you need to explain what's the most important, what are the important roles of the angiotensin 2. Okay, so first and foremost, it helps to stimulate. It helps to stimulate the secretion of aldosterone that is found in the adrenal cortex. And aldosterone, its function is to reabsorb sodium, and when sodium is being reabsorbed, it will take along with it water. That's how it can increase blood volume. Okay, and then another important role of angiotensin 2, it stimulates the secretion of antidiuretic hormones at the posterior. Ni kena tahu sebab secret, but where? So ADH from the posterior pituitary gland that will cause an increase in water retention at the convoluting tube. And then it also stimulates the third center in the hypothalamus, which of course this will cause increase in fluid uptake and then volume shower. Okay. And then this is the most important, I think the most important, one of the important direct effect of angiotensin 2, because it's a potent vasoconstrictor, so it helps to vasoconstrict the blood vessels when there's increasing resistance. It will of the local side, it will of course cause increased total peripheral resistance, and this, remember, will cause increase in blood pressure. Dah habis summary, alhamdulillah. So what's important, I want you to appreciate, is the factors, the determinants of mean arterial pressure, the upper TPR, and then the relationship. What are the relationships? This proportionate, okay? And then appreciate the blood pressure regulatory mechanism, the three differences between the short term and long term, okay, in terms of the response, how fast it can produce response, it can produce change, blood pressure change, and then what does it mediate, whether the blood vessels damage to the heart rate or the contraction of the heart, or whether it's the blood volume, through the kidneys to the renal system. And then how it is being manipulated, this parameters being manipulated through the mediation of the nerves or the hormones. So, and then examples, please appreciate the examples of the short-term blood pressure regulatory mechanisms and what differentiates them. In other words, what activates them. Okay, at what level of mean arterial pressure it's activated. Now remember, when you want to talk about the baroreceptor reflex, remember, it's a negative feedback control mechanism, and the talk and explain by explaining the 5 components: the stimulus, the receptors, and then where it is, what it is, and then the afferent vagus and the glossopharyngeal nerve, and then the integrating center, nucleus ductus solitari, and the CIC or CAC, and then the efferent nerves, and then the respective efferent nerves that synapse to the effector organs. Now, so let's go back to the case that we've looked that I've shown you earlier. The healthy 21-year-old athlete. Okay, the athlete wants to perform a 100-meter run, and then a random check of his blood pressure, we notice it's high lah, and we know already it's high normal. So we are supposed, then we ask you to discuss. So when we ask you to discuss, you start by defining blood pressure and what is normal and what is not. And then what are the determinants of blood pressure and what are the regulatory mechanism. And in terms of this young bloke, yeah, the brain, remember we talk about how, you know, even though it's an autonomic nervous system, it's a peripheral system, yeah, it can be influenced by the higher level, of the cortex, the cerebral cortex. So the brain can also influence the brain stems or the integrating center by giving inputs, and in this case, it's premeditation. That athletes usually premeditate. They sort of anticipate what's going to come by having this. That's why this pep talk or this motivational talk before any activities is very important to psych you up, right? So the premeditation has actually caused the central nervous system to exert influence the brainstem and cause the integrating center to receive stimulus to activate the sympathetic activation. So it's a learned behavior, right? That's why practice is important. Right, so this will not just trigger the autonomic nervous system, it will also cause the somatic nervous system to be activated as well. So we know already just now, we talk about the regulation. Dan tadi sebutkan what are the determinants, what are the factors that affect blood pressure. You have to talk, you have to define, and then you talk about the autonomic nervous system activation, and of course the deactivation of the parasympathetic nervous system. And you talk about the blood vessels, you talk about the heart, and don't forget the adrenal medulla and the skeletal muscles as well. And in this case, in particular example, you can continue blabbering about the baroreceptor reflex, what happened to it, and then you talk about the neurotransmitter, talk about the receptors, how increase TPR, how increase cardiac output, okay? And then if you want, you can also talk about the regional circulation, in other words, the blood supply of the skeletal muscles and the heart, because during increased sympathetic activation, strenuous activity anticipated, it needs to be well functioned, well oiled, it needs to be very efficient, therefore it needs continuous blood supply. So locally it has its own regional, it has its own local control that is separate from the nervous system. The sympathetic activation, as we know, will cause vasoconstriction, but not at the heart circulation, coronary circulation, and at the skeletal muscle circulation, it's highly dense with beta-2 receptors, therefore attract adrenaline, and when adrenaline is attracted to these local areas, so despite the running, despite the contracting of the skeletal muscles, despite the increased pumping of the heart that causes strenuous activity, stress to the heart, and squeezing the blood vessel, the coronary circulation, the tissues of the skeletal muscles and the heart cardiac muscle can still be vital and function well, because the local the regional circulation, the local blood flow regulatory mechanism is separate from the nervous system, which is for the heart and skeletal muscles, the most important local regulatory mechanism is the apa dia? Itu you all kena belajar ya, intrinsic dengan extrinsic. Intrinsic itu local lah, and this one is the metabolic. In other words, the increase in carbon dioxide, increase in lactic acid will cause vasodilation as well. Okay, and then for the heart and the skeletal muscles, even though sympathetic activation occurs, but because it is highly dense with the two receptors, beta-2 receptors, it causes vasodilation. Therefore, local continuous supply of blood of the local tissues is maintained. So ini cara nak sebut lah ya. This one simple je, regional circulation, you just read it up and you know. Okay, so just add on. Tu distinction lah tu. Now the second scenario, okay. Oh, sebab itu start lambat tadi. Okay, 5 more minutes for me. Now another scenario, a 21-year-old male presents to the emergency with profuse bleeding from several stab wounds. On examination, his extremities are cold and clammy. His pulse rate is high lah kan, 120 beats per minute. Saya saja letak 120 beats per minute. Kalau lebih kau kena panggil cardiologist. And this one, his mean arterial pressure is 45 mm mercury. In other words, low. Okay, so macam biasalah. So tell me about this person. Healthy young man, but during the emergency, so what's happening? So you start. Well, mean arterial pressure, you start dengan definition, and then what is determined by this, and is regulated by this. And this patient is are asked to explain the hemodynamic changes. In other words, can you explain the cold extremities, the heart rate, and the mean arterial pressure? So you need to talk about the hemodynamics. Apa hemodynamic? Changes in anything with the blood lah, the blood volume atau blood pressure sama. Right, and then we talk about the regulation mechanism. So this is the answer scheme. So mula apa dia mean arterial pressure, blah blah blah, what are the determinants, and the hemodynamics ni you explain how the because of the profuse bleeding, patient is losing volume, blood volume. So what happens when this blood volume is reduced? There's reduced in venous return. And you know when there's reduced in venous return, there's reduced in preload. In other words, the ventricular and diastolic volume also will be reduced. And this causes reduction of the stroke volume. Reduction of stroke volume causes reduction of cardiac output, and the net effect is reduction of the blood pressure as seen in this patient, right? And then the heart rate is actually a compensatory mechanism of the heart in view of the reduction of the blood volume and also the blood pressure. Okay. Right. So acutely, what blood pressure regulatory mechanism that takes place? Yeah. So because the mean arterial pressure that is below 60, so I will make it very clear. So the short-term blood pressure regulatory mechanism that is most important, that is triggered, that is activated, is the CNS ischemic response, because it's too low. So this one is triggered. Then you talk about others like chemoreceptors. One that is stabilizes a bit, it is maintained. It manages to protect the brain from ischemia. Yeah, if it's about 80 millimeter mercury, the mean arterial pressure is about 80 millimeter mercury, and then the chemoreceptor will be activated. Okay, all right, to ensure to help maintain the blood pressure. But of course, if it's 80 millimeter above 80 millimeter mercury, in particular, it's or in concurrently, because this one is activated at 80. Concurrently, baroreceptor can still detect the low blood pressure and then convey the message to the integrating center, the NTS, and the NTS will cause activation of sympathetic activation as well. Okay, so but you must first and foremost mention the CNS ischemic response because of the mean arterial pressure. It shows that you're thinking, not just regurgitating from the book. Right, and then of course, after a few minutes, the RAS will take over. Start talking about RAS lah. So this is the summary that you can look at it later in quiet time, lepas break nanti balik rumah, tenang-tenang, look at it. Because this is a very good diagram. It tells you what are the stimulus, and it tells you whether or not it will cause inhibition or it will stimulate the parameters, and then what are the end product. At the end of the day, we want to know about the cardiac output, right? So this is very good. Yeah, have a read. Okay, so everything is summarized there. Alhamdulillah. Okay, habis. Alhamdulillah. I'm going to stop sharing. Just want to thank everyone for listening, and hopefully you get some benefit from this session. I will give the slides to yeah, and then hopefully you can have it. And stay calm, stay safe. Inshallah, you can do it. It's just a revision. And I just want to highlight your colleagues, Shaza did a very good presentation on cardiac output. If I don't have time to cover them, cardiac output, cardiac cycle, you can get her to present. And also, siapa seorang lagi tu? Amira also presented well, and I asked her to go into details of her lectures. I think they probably record. We can have a listen, because I listened together with the rest. Okay, enough from me now. Anything else you can just PM, insyaAllah. Okay, Assalamualaikum warahmatullahi wabarakatuh.
Tasrin,
Yeah.
Sorry, Shaza here.
Yes,
Nak tanya
Shaza.
soalan.
Yes, Shaza.
It's regarding cardiac output and trying to relate it into our kind of clinical practice. So what happens to our cardiac output during supine position in surgery, and head down position in surgery, and also when we have laparoscopic surgeries, we increase the intra-abdominal pressure. So what happens to our cardiac output in these different situations?
In that situation, you have to discuss that first and foremost. You have to know the status or the basic, the baseline of the patient's, what do you call that, the cardiac output lah. In this case, because you would assume in surgery, usually patient is losing volume, losing blood, right? So if the gravitational aspect is also important in blood pressure regulatory mechanism, in maintaining the hemodynamics. So we have removed that. Okay, remove that. And then at the same time, we do not want to exert any what do you call that, extra pressure to the heart. So this supine, for instance, in supine position, supine position will actually reduce stresses on the heart. So depending on, first it eliminates the gravitational aspect of it, because when there's gravitational, it will cause further the heart to the blood volume moving away from the heart. But then secondly, it also helps to apart from maintaining suboptimum blood volume, it also prevents from unnecessary what do you call that, exertion to the heart, because that's why NS is very particular about physiology and pharmacology during the master's training, because it needs to be well maintained, because otherwise it will be too much. Because most time doing this practice with surgery, we are concerned about the losing of volume. That's why it will maintain the optimal cardiac output by removing the gravitational effect. That's how I see it.
I think that's all questions that we can allow for the session, because we already queue for the next session because the current stuff. Thank you very much to Dr. Azri for the time and for the presentation and lecture. It's a very useful course. That's all for the session. And please check your WhatsApp group for the other participants, because the coming start would like us to join in the Google Meet. Okay, we will change our channel. Kindly please